Well, by way of introduction, for people I've not met before, I've trained in Leicester. I've been a GP in Leicester for 22 many years, and have been out of partnership now for 5 years and working as a portfolio GP. And a couple have already asked me what that means. It's a GP who works across different practices and sometimes in specialty services as well, with a special interest. And the thing that binds a lot of that work together I'm doing at the moment is a real passion, and I've always had this, about making the primary-secondary care interface work much better, so the patient always knows where they are in a journey and who they go to, and also the clinicians know what their role is within that pathway. As Helen said, I've been working, the true leaders, I think, in this pathway development probably can't make it today, but I've been taken on for sort of a day or two a month to, I think, be the glue between the work that Martin Newey's doing, a spinal surgeon at UHL, and Mel Galley in the development of the musculoskeletal triage in West Leicestershire, to try and make this national vision work, particularly with spinal care. So on to the title. Will LLR meet national standards? And I'm glad that we've been given a free sort of vision remit for this, because I'm still not sure whether we will anytime soon, but maybe this forum can be the difference to make that sort of happen. Because at the moment we've come to something of a perfect storm of there being really good, robust national guidelines, a real willingness locally amongst several people to make sure there is a good and receptive spinal pathway. But I think at the moment it's not really got onto the commissioning agenda, and I think that's our next role. Back pain, a real problem. Lots of stats there. But I think the sort of underlying theme here is back pain is a long-term condition for probably a good 40% of people that have an episode of back pain. And unlike heart failure, diabetes, COPD, there's no coordination of people with a chronic lapsing condition for back pain, as there might be for those other long-term conditions. And one in probably about 10 people in this room will have had an episode of back pain this year. Statistically, maybe 5 of us will struggle with recurrent back pain. And this is a condition that affects working age people predominantly, which is why it has such an economic impact on the economy. So moving on to the local picture with back pain. As you've just said, I think I did a clinic with Philip Sell back in 1993, and it was being talked about then how Philip did some work on triage and referral. And so it's been talked about for many years, but last year UHL, under Martin Newey's leadership, actually started going with a triage process that I'll come on to. And we're about probably 6-7 months into that now. It's certainly an LLR priority to redesign the musculoskeletal pathway, the idea that all musculoskeletal referrals will go through some form of primary care-based triage in the future. I can't think of any other area in medicine where we have so many different referral routes into secondary care, as well as a spine clinic. There's rheumatology, there's pain clinics, there's all a number of different flavors of physiotherapy services that then often recommend back to us to refer. I think there are 1 or 2 specialty services that can refer straight in. It's a myriad of different routes for people to get into the service and receive different types of care. The activity is increasing, and I think that the bottom point there, the actual access to the sorts of care and interventions that NICE has, the so-called multimodal therapies, and there are different shapes and flavors of those. The primary care access to those is very fragmented, and if you're in Loughborough, you might be lucky. If you're in East Leicester, you might not have any. It's a real mess. So the UHL process, I'm dealing with what UHL have decided to do off their own bat anyway, and part of it is a paper-based triage. There's all the referrals coming in are analysed by a spine surgeon and an ESP or a GPSI. And that triage process then decides who sees that patient next. And around 35% went to a specialist clinic. It was felt that was the right way. But 65% actually maybe that they need a sort of a face-to-face triage to see what's the actual need here. And I think between Martin and I, we didn't agree on everything, but we did have a consensus that 20% of the referrals from general practice were missing really important information to guide a meaningful assessment in primary care, and probably 40% could have been managed in primary care. Moving on to some of the stats, and these are the personal stats for the 3 months that I spent a half day a week for 3 months with the clinic just to see what the caseload was like, and this is a reflection on that. Around 30% and up to 50% in some clinics, people discharged at first consultation, and this is for a surgery clinic. So the idea of surgery is to assess for maybe some form of intervention. GPs do not have, or officially don't have, direct access to MRIs, so a lot of GPs would refer in just to get the MRI, and in fact, not having that, 1 in 4 cases, it was just wasting time that wasn't available for the consultation. Only about 1 in 5 cases went then on to see a spinal specialist, and interestingly, quite a few of these people are already under a chronic pain clinic, but were referred to spinal clinic as well, with the same questions being asked. And I think consistent figure here, at that face-to-face clinic, this is a value judgment, but 40% roughly could be managed within primary care and not gone anywhere near a hospital at all. Now this is all in the context of the LLR Alliance priorities, and there's 2 to pick out here. I think it's still an aspiration that all MSK referrals from GPs will go through a primary care-based triage process. It's already active in West Leicester. I know the numbers are increasing, and seeing how it's working, I think that's working very well. But there's no timescales attached to how and when that will roll out at this stage. And alongside that, there is a very fragmented service across the city and county about who people, or GPs in particular, refer to for physiotherapy and the sort of services that are accessible. And of course, open access is, I think, a government aspiration. How does that fit in? So at the moment, there's a review process going on about how physiotherapy service is going to look across the whole patch. I'm not quite sure when that finishes, but it's not long, is it?
No, we'll be doing a paper for middle of July.
Middle of July, okay. Now, national plans. There is now a body within the NHS who are dedicated to support the regions begin to follow evidence-based guidelines, and these are guidelines published in December 2014 about how you manage beginning to end aspects of people with spinal pain. And we had a meeting about 10 days ago with Sarah Kirtland, who's part of that process. I'd like to hope that we in LLR can aim to be, they've already gone live in the Northeast, maybe in the second or third, be one of the pioneers in this area if we begin to achieve consensus through the Alliance. I'll only focus really on the first part of that pathway. I think this is the worst flow diagram I've ever seen in a national document. It's a real mess. So we can invest in something to make that more palatable. But anyway, this first bit is really about primary care management. The model here is that somebody presents to a GP. A GP with the right education, I've spoken to Rish about how that would work. We start to get the right messages and use the right tools to assess what's the risk here. Is this somebody who just needs a bit of advice, a bit of paracetamol, well, not it's ibuprofen these days, isn't it? And get back to living, or is it somebody who's going to get very fearful of their condition, get deconditioned, and become a chronic back pain? The second part of this, and this is where the real key part of this is that at 6 weeks, and if the start back tool, which is an assessment for people who are beginning to get a lot of fear about their pain and really beginning to withdraw from normal life, is there should be a series of triage and treat practitioners, easily accessible for patients and their GPs, to begin to get, take the next step as, where do we go now? So who are these triage and treat practitioners? And the analogy I'd use is it's a bit like the heart failure, diabetes, COPD nurses. And these people have expertise in their area, but very good at managing a case as it changes, and know which services they can access, whether in primary care and secondary care. Because of the very nature of MSK conditions, it's not just nurses in this case, there is a role for extended scope physios. There's a lot of debate about this because I think specialist nurses in this field traditionally haven't been the preferred choice. But there are arguments at this level that the nursing expertise would be the ideal expertise, and the extended physios who are in short supply will be further down the line. And I think in Leicester, we would look at those being based in hubs or federations. And that's the early assessment of where we are with this. They say be able to interpret MRI scans, but also begin to offer that early advice about managing pain. And then if they need to, they will take the process of referring on to the next stage and be able to request an MRI scan ahead of that secondary care consultation. Going back to this awful diagram again, I thought I'd put this in because of course the whole patient choice agenda would seem to be wiped out by this model. But the way West Leicester have developed their musculoskeletal hub, I think has been the perfect framework for this. That the referral goes into the hub, the early management is through the hub, but when you need that provider service, it's at that point that the patient choice comes in. And so the fear from the various physio providers out there that if there's one model, there'll be one big provider and people will lose business. Well, no, at this stage, this is where the choosing book could come in.
And that's done through the Alliance. And actually, a lot of the GPs have fed back to me that really they probably haven't given patient's choice, true patient's choice, until they started to use this model. So, you know, I mean, they do get a real choice of, they're told what the wait times are across the board and even over the borders.
Yeah, indeed. And of course then, to pick on that point, I think most of us, except where we have our own physio or a physio very locally, will just refer to a big physio service. If you know that if you can travel to Loughborough, you're going to get an excellent bank service, that might be something that you'd signpost. Back in February, we presented where we were to the clinical reference group of the Alliance and asked them to agree 5 broad principles about moving forward. And that, first I've already talked about, the hubs being the entry into this service. The NHS England Pathfinder, which is the basis of this national support service, the NHS being the framework for how we manage spinal care here. And then the final one's about using the PRISM, the Pathway Referral Information System Management. If for those of you who don't know this is a facility on GP systems where if you want to refer, then we're trying to create an environment where GPs can use this to create a referral, produce a patient leaflet, make sure that they've done all the workup perhaps for a referral, and then refer things on. It's an information resource as well as a management system, and quite neatly, where it works very well, ties up all the stuff you've put in your notes into a push button referral. And the 2 areas that are slightly different for people with new first onset pain, never had a back pain before, it's a different pathway for them, should be quicker in some ways. People who've had problems that are coming and going, that's a different pathway with different providers, and so the idea is we'll have 2 strands through PRISM for that. And these 2 points at the bottom just making the point, it is a resource of information for the GP and for the patient, and probably underutilised at the moment. So, the next point, will we achieve this here in LLR? Everything's well placed, but at this point it's about the hard discussions and where do we find the money? And so there needs to be consensus really across these 3 bodies, areas, institutions, whatever you want to call them. And I think the key point is if the Joint Commissioning Board are given a presentation and say, yes, we want to commission this kind of service, and that's in next month?
Yes, but one of the things we're trying to look at is we spend a lot of money on this already. So it's not about looking for new money, it's looking about how we can spend the current money that we spend differently to provide a service that will have better outcomes and actually possibly will cost less going forward, because a lot of these patients can see, we've followed patients through, and they can see 3 or 4 rheumatologists because they don't get the answer they like from one. A couple of orthopaedic surgeons, they can have been in the pain clinic, they're literally, and they're on the GP's doorstep nearly weekly. So the amount of time that takes, if you can sort that out and get that patient feeling that actually they know what's what, accepting there's no cure, but actually working on what they can do to make their life tolerable, you've achieved something. And that's the sort of thing we need to be looking at, as opposed to, we're not looking for new cash, we're looking for what we're existingly spending and reusing it differently to make it a better service and a more efficient and effective service.
I think the bottom one here, there's still, as far as I'm aware, has not been, and people have really tried, a forum where the spinal clinic, pain management, rheumatology have all got together and agreed that this is a good framework, or explain why this is not a good framework. That's vital, and I don't know how this forum can help that happen. Timescales for this will only work if we have a sort of a hub environment for the referrals to go to. There are no timescales attached to that at the moment. Patient choice I've talked about. It'd be interesting to hear what the patient representatives here think of deferring that patient choice to a level beyond the GP. The good news is that there's a whole bunch of spreadsheets that were sent to me last Friday, which I hope somebody will understand, about creating a business case that the North East have done to actually go ahead to use this model, and they've used some transformational funding to grease the wheels, but they are working in a cost-neutral way to save money on particularly secondary care interventions to fund this triage and treat practitioner in a more coordinated model. And don't forget, one thing that the health economy is not good at, and I've tried with absolute failure to get people to think about, is there are pots of money out there that you can get in to help initiatives around certain areas, and these are some of them. I know Arthritis Research UK are putting a lot of investment at the moment to completely redesign the way they design their patient information, and they have been interested in maybe making Leicestershire the base to begin to look at that. It's just how do we make that happen? DWP funding, there's big pots of funding, there's a big pot of funding coming up to try and keep people at work. Maybe we could track that into what we're doing, and certainly bringing in the local research funding. That's an opportunity. So I think I'll finish there, but certainly those things taking place and how that's going to happen, I think, are the key questions for: are we going to move forward, and are we going to meet national standards?